Welcome to This Explainer. We're jumping right into a massive clinical friction point in emergency neurology today, administering intravenous thrombolysis to acute ischemic stroke patients who are on subtherapeutic warfarin. Now, you already know the high stakes of acute recanalization therapy, but today we're really unpacking the conflicting literature surrounding the safety of pulling that trigger. So, the scenario is pretty universal. You're evaluating an acute ischemic stroke patient, and the lab calls back with an INR of 1.7 or below. Under our current guidelines, that number flashes green for TPA. At the bedside, it feels totally straightforward. But when you actually dive into the literature, the safety of acting on that single, static lab value, well, it's highly contested. The official AHA and ASA guidelines firmly establish this 1.7 threshold as our foundational rulebook for IVT eligibility. It's really become the standard operating procedure that comprehensive stroke centers rely on to stratify bleeding risk in patients with prior oral anticoagulant use. But how exactly did we arrive at this specific physiological threshold? The origin of that cutoff is actually kind of surprising. As Dr. Eric Peterson famously pointed out, patients on oral anticoagulants were systematically excluded from those early major trials like NINDS and ECAS. So the recommendations for low-dose warfarin patients were essentially, in his words, shotgunned into the guidelines without much robust initial evidence to back them up. Despite that slightly shaky origin story, subsequent large registry data seemingly validates the threshold. For instance, data from the massive Get With the Guidelines stroke registry looked at over 1,800 warfarin users and found zero increased risk of symptomatic intracranial hemorrhage. On top of that, a Romanian cohort observing prior acinocumarol users showed absolutely no difference in hemorrhage or mortality rates compared to non-users. So on a population level, this data is highly reassuring, right? It suggests patients at or below this threshold tolerate lytics just about as well as those not on anticoagulation at all. But objective clinical practice requires us to really pressure test that reassurance. We have to ask, does a subtherapeutic INR truly guarantee a safe bleeding profile throughout the entire TPA window? We're forced to question whether a single point-of-care lab value actually reflects a patient's dynamic coagulation status, or if the pharmacokinetic reality of warfarin is just far more unpredictable post-lysis. Things get really interesting when we juxtapose that reassuring registry data against prospective findings published in Neurology by Rucker and colleagues. Because suddenly, the narrative flips. Where retrospective registries show no increased risk, the prospective data reveals a staggering four-fold increased risk of symptomatic intracranial and major systemic bleeding in subtherapeutic warfarin users. We're talking a highly significant odds ratio of 4.2. The danger here really lies in the distribution margins. If you look at the Romanian study, the median INR for patients on coumarinic anticoagulants was a theoretically safe 1.4, but the upper quartile tells a totally different story. 20% of those patients were sitting right at that 1.7 limit. It really exposes the razor-thin margin where the risk of hemorrhagic transformation can suddenly and catastrophically escalate. Digging deeper into Rucker's prospective data reveals a critical warning sign about those exact margins. Out of 548 patients receiving IV TPA, 15 were taking warfarin up to the day of, or the day before, their stroke. Not only did they face that 4.2 odds ratio for hemorrhage, but get this, half of the patients who bled actually showed an INR spike above 1.7 within 6 hours post-thrombolysis. So that admission RAB value, it was just a temporary snapshot masking a delayed, dynamic danger as the warfarin continued to exert its pharmacokinetic effect. So we have this dramatic seesaw of evidence, population safety on one side, prospective danger on the other. And that brings us to a massive hidden variable in the current literature, the role of reversal agents. As highlighted in Neurology Today, it remains entirely unclear whether patients in those massive, reassuring registry studies actually received reversal agents like 4-factor PCC or vitamin K prior to TPA administration. This is a crucial limitation in the dataset. It severely complicates how we interpret clearance rates, obscures the true baseline bleeding risk of subtherapeutic warfarin alone, and absolutely muddies our bedside clinical judgment. Because if the registries only look safe because those patients were aggressively reversed, applying that same safety profile to an unreversed patient at an INR of 1.6 is a pretty dangerous logical leap. Which means we end right where we began, just with a much sharper lens. The lab calls, the INR is 1.6. You have massive retrospective registries promising safety on one hand, weighed against rigorous prospective data warning of a fourfold bleeding risk and dynamic post-TPI-INR spikes on the other. Oh, and you can't forget that massive, unaccounted variable of prior reversal agents. So, how will you synthesize this clinical friction the next time you're holding the syringe? We hope this explainer helps you weigh the evidence just a bit more critically on your next shift.